representatives to add your name and your affiliation or organization you're working with to the Teams chat to confirm your attendance. I'm really excited that we're using this as our new way to do roll call to squeeze even more time into what I know goes quickly this hour. So as we give folks a final minute to join, please add your name in the chat, representatives, and we'll go ahead and mark you as present, and then we'll go ahead and get started. Thank you all. Perfect. Okay. We are nearing quorum, so we have about 1 more minute. I want to ask for those that are joining, our representatives that are joining us via phone, and you aren't able to add to the chat, feel free to come off mute now and let us know that you're here. Just want to make sure we can mark you as present. All right, with that, I'm going to move us to our agenda. So really looking forward to our time together this afternoon. Before we do that, I'm seeing one hand raised on the phone. Do you want to come off mute and introduce yourself? If you're talking right now, you may still be muted. That sneaky double mute. So feel free to interrupt if you weren't able to come off, but just want to thank you all for joining. I was disappointed to have to miss last month's meeting. I was tied up at a hearing at the legislature, but really enjoyed getting to watch that recording after, and want to thank my team again for carrying that work forward during what was a really busy time and really having an excellent discussion on youth peer support. So for today, the time that we're going to spend is really focused on screening and assessment. We'll go through a few updates since that May meeting. Excited to share some legislative updates as well. But I'm thrilled for Dr. Christine Pebbles, who is our behavioral health clinical advisor here for the Children's Behavioral Health Transformation, to walk through a little bit more about what the settlement requires of the state of Nevada as it relates to screening and assessment, and really tee up the first of what will be many discussions on screening and assessment in our state and the path that we'll move towards over the coming years. So with that, we have reached quorum, so I'm going to go ahead and dive in. So follow-ups from our May working group here. I will start with the legislative session recap. It was quite a busy 120 days. This is the calendar I had on my desk when I crossed off every day there. But it was really exciting to see a lot of good work come to fruition. So I wanted to highlight a few things here that really directly relate to our children's behavioral health work. So first and foremost, want to acknowledge that we are undergoing a pretty significant reorganization here at Nevada Medicaid. Really excited for this work to come. That will be official on July 1st. So stay tuned for a lot more details to come publicly on that date, including our new logo and new design, which I'm really excited to introduce to you all. But what that means for our children's behavioral health transformation work is honestly only good things and not too many significant impacts. So this remains a top priority for Medicaid, for the Nevada Health Authority, for our partners at the new Division of Human Services, and of course for the governor's office as well. And so we're really working hard in the midst of a lot of organizational change to protect the time and teams that are working on this from all of that swirl to ensure that we can really continue to move this forward with no impact. I think the exciting news is that aligning many of the teams that are coming under the Health Authority umbrella will only benefit the work of the Children's Behavioral Health Transformation. For example, pulling in our healthcare quality and licensing team will really help us as we stand up new benefits that require licensure for new facility types. It will really try to align that process as well. But know that this work will continue to be really collaborative with our sister agencies, both within the Health Authority and within the Division of Human Services. That really won't change. That's been ongoing behind the scenes. We're meeting with our leaders and our team kind of program leads within those departments on a very regular basis, and we'll continue to do so throughout this transition. So want to acknowledge that first and then move to a couple of our bills. So AB 514 touches on behavioral health residential services, so really excited for what would be type a step down level of residential care for both kids and adults. So for kids, it would be kind of below the PRTF level, but really to ensure that youth that aren't prepared or ready, or their families aren't prepared to be able to take them back from a PRTF, have another alternative clinical setting. So excited for that model to be developed and for us to go through the federal approval process. SB 165 is really looking upstream at behavioral health prevention and early intervention services. It creates a new training and certification program for a new provider type that's a bachelor's level provider. This will align with some existing provider types we have at Nevada Medicaid, which is great, our QMHA model. So we will be able to incorporate those in new providers into our Medicaid model as soon as they are trained and ready to be in our state, which is exciting. SB 300, I'm kind of doing a loop, so apologies, I'm jumping all over between these boxes. It's really going to help our FQHCs expand the types of behavioral health providers that can be part of their practice, and will also increase rates for opioid use disorder therapies, which is exciting. And at the bottom, so SB 353 will require us to seek federal approval for reimbursement for services provided by trainees at university-affiliated behavioral health clinics. So really excited about potential new providers that can receive Medicaid reimbursement for excellent work that they're already doing through our universities right now. Also excited for a number of our budget requests to get approved. We requested funding to develop Medicaid reimbursement for a first episode psychosis program. So developing that Medicaid payment will be something that we're undergoing right now, as well as increasing rates for two crucial components of our behavioral health continuum, which are partial hospitalization and day treatment services as well. So there's a lot of information there. I want to call out that we will have a much deeper dive in our quarterly stakeholder meeting, and we'll give updates on what those implementation timelines look like and share a little bit more about when we will be holding public workshops to solicit your input on how we design this policy. There is the real work really is just beginning right now that legislative session ends. And so there's going to be a lot more opportunities for you all to join us and provide your input throughout this process. So wanted to share a little bit more about some of the exciting work that's happening, and again, look forward to your partnership through it all. I also want to touch on a couple other follow-ups from May. So a few things that you heard updates on from our team here. First is youth peer support policy. It was an excellent discussion, and I want to thank you all for that feedback. I want to confirm that we have submitted our state plan amendment to CMS that incorporates that feedback that was presented at our June public hearing. So look forward to providing updates and really working with this group to develop that benefit as we receive federal approval in the months ahead. Also wanted to follow up on the outpatient behavioral health rate increases, which my colleague Matt went over last month. Those are also with CMS, still pending approval. We're going back and forth on a couple questions, but hope to get that approved very soon. I know that there's been discussion of additional rate increases, and we are still waiting for those federal Medicaid policy changes to be finalized. Once we know that and have a better sense of the impacts to our budget on those federal policy changes, we will continue to keep everyone posted on the path forward there. Do want to call out that is something more generally that impacts all of this work, of course. For those following the back and forth in Washington, D.C., there are a number of changes that could or could not impact all aspects of our work. And so know that our team is monitoring those very closely and modeling those impacts. And we're eager to see kind of where things end up landing so we can go through the process of really implementing those and understanding better where that leaves us. So just want to acknowledge that is still ongoing and may still be ongoing the next time we meet, but that we are monitoring it closely and look forward to working with this group along with our other stakeholders on the path forward once those final policy changes are completed. Quick update, shifting gears on the Department of Justice piece. On our implementation plan, so those that have read that closely, like me, you may have seen item number 105 highlighted, which is one of our first exciting deliverables, which is that implementation plan the state will really provide in response to our independent reviewers review plan. Just want to call out for you all to be aware when that's coming. It will likely be in early fall. Initially, this was planned to be drafted in July. But because of some contracting delays with our independent reviewer, the Department of Justice actually extended that to August. So I just want to call out that is still coming. It's in the works. Our team is working hard on that now, and it really reflects everything that we've gotten feedback on from you all, and we'll continue to iterate on in the months ahead and look forward to your feedback on that once it's published this fall. And last but not least, my final commercial before we move to the real fun discussion. I want to thank each and every one of you that responded to our request for public comment on the specialized managed care plan. We have received excellent feedback that our team has spent the last month really digging into in depth, and we're utilizing that to inform our early design conversations on this plan. Know that we're going to have a lot more feedback opportunities on our specialty plan design. We're going to talk about it in this forum, and we'll have additional meetings deadlines for those that are interested in going deeper on certain topics. So know that that's the first of many opportunities if you miss that deadline, but also want to thank those that spent a lot of time reviewing and providing really thoughtful feedback. And we're excited to continue to move this process forward. So with that, thank you for your patience with those updates, and I'm excited to turn it over to Dr. Pebbles to talk a little bit more, to tee up a discussion really on our screening and assessment system here. So Dr. Pebbles, I'll turn it over to you.
Good evening. Thank you for joining us. So just briefly, for those of you who haven't had me in the meetings before, I'm Christine Pebbles. I'm a psychiatric nurse practitioner. I do work in the field. I always joke around. I have 3 part-time jobs at all times, and it's no different now. And so I'm the clinical advisor for the state working on this transformation. So let's kind of go over some of the information that we have. So we have some goals today for today's discussion. Mainly, we want to give you kind of an overview of the settlement requirements and the verbiage. It does get kind of confusing, and so I wanted to make sure to delineate everything and give you the difference between all of the different assessments and tools that they refer to in the settlement themselves, in the settlement itself, excuse me. I'm going to share a case study to just kind of illustrate what our thinking is as far as how this process hopefully will go in the future and relate it to the specialty plan that is going to be organized soon. And then getting your feedback as well. The feedback is the most important part. Obviously, we greatly value your expertise, your experience, everything that you kind of bring to this group. We value it greatly. And we want to make sure to leave enough time to get your feedback. And this is going to be mostly on how to organize this assessment system using the screening and assessment tools we'll discuss to make sure that it works best for Nevada. You know, we have a very unique geographic location. We have a very unique situation in Nevada. And we want to make sure that it applies to everyone involved. And so this is going to be the first of many discussions. So don't feel like this is your last chance to make any comment or to tell us about your experience. There's going to be many, many opportunities for you to do that. And the selection of the tools will be at a much later date, just so you're aware. So let's move on to the wonderful verbiage from the settlement. So this is a lot of legal jargon. I wanted to make sure to clarify it all for you. So mainly we are to adopt a set of behavioral health screening tools. Keyword is set. So it's not just one, it's not just 2. We need to develop a set of tools that can be utilized in many different environments because we know kids are going to be screened in many different areas, right? It could be juvenile detention. It could be in the child welfare shelters. It could be at a pediatric office, at a primary care office, lots of different environments. And so that's why the settlement delineates a set of tools. And these tools are to be brief. They have to be nationally recognized, validated tools that we can see in research helps us to develop a diagnosis and a treatment plan, right? So something that gives us a heads up as to, is there something that we need to be aware of? Something like depression, anxiety, ADHD, autism, anything like that, that we can further help a child with. It needs to be a tool that would kind of give us a warning or give us a flag as to this is what's going on, so we can then make sure that that child goes to the level of care that's appropriate for them. The screening tool, there's a couple different things. The screening tool, as far as the settlement is concerned, there are different circumstances where screening tools need to be utilized, but of course, we're going to develop that protocol as well, in addition to what is told to us in the screening. That protocol will be implemented and kind of melded into the EPSDT screening, so the early and periodic screening. But to give you kind of an example is we would use these screening tools if a child enters child welfare, juvenile justice, developmental services, and they have not already been screened. That's something that was set apart in this settlement. As well, we need to develop some collaborative agreements with county entities. So again, this is juvenile detention, this is the foster care shelters, that when a child enters that shelter within a specific protocol set, they are screened and assessed to make sure that, again, we're not missing anything, right? That they're getting the care that they need at that point in time to be more preventative in nature. And then there's a new requirement. That's why we discussed a protocol that kids that are under the Medicaid umbrella should be receiving some periodic screening. And again, the tools will be utilized for that as well. The specifics for that will be determined at a later date, but that will be a periodic screening that, again, will be more preventative in nature. And later down the line, after all this is done, we'll then test it, monitor compliance, make sure it's being done correctly, making sure that it's quality as well. So those are the main components of the agreement and what it kind of lays out. And so here's kind of a quick overview of the key terms. Again, it is confusing. Before I became a nurse practitioner, I was an administrative assistant for about 12 years, an executive assistant, and I even worked for large insurance corporations. Previous to that, I was a legal assistant. So I felt like I had to stretch my legal muscles and read through all this stuff. So just to kind of give you an idea, there are 3 different assessments. You'll see if you read the settlement, a lot of the times they refer to all of them as tools. So we wanted to make sure to separate them so you were aware of what the different levels were. The first level is a screening tool that we just discussed, right? Again, brief, validated, nationally recognized. This applies to all youth in Nevada with the goal to be having a website, a toll-free number that they can call or contact in order to get additional assistance. And that screening tool is the first gate and the first step to them getting the help that they need. So this can be done in many different environments. The second step is a clinical assessment. So that screening tool is something in clinical practice is also known as a rating scale, a questionnaire, and we'll give you some examples later on in the presentation. But screening tool is the first step, first gate. That second gate is a clinical assessment. That can be done by trained personnel if the tool that's selected requires it. To just give you a broad example, a CANS tool, right? So the comprehensive tool that a lot of different agencies use, that would be considered a clinical assessment. So that's where we get a little bit more history about the kid, what's going on, what are the needs, what are the strengths, and then that helps us to inform the next level of care as far as where they would be best served. And that particular assessment, the clinical assessment, can be skipped. If the kid is really acute as far as their symptoms are concerned, we can skip that and go directly to the next level, which is a comprehensive assessment. The settlement did say the comprehensive assessment has to be conducted by a QMHP, so a qualified mental health professional. So it can be a psychiatrist, it can be a psychiatric nurse practitioner like myself, a psychologist, LCSW, MFTs. Those qualified mental health professionals are the persons that would be responsible for completing this comprehensive assessment. So if you fall into that category, you know very well what that means. That's collecting the history. For myself, I have to collect medical history, social history, educational history. We get a much larger picture of the child. And that's what we use to then diagnose and develop a treatment plan. When there's a child in need, especially if they're already in a residential treatment facility, that is really important. They need a comprehensive assessment so we understand the full picture. This also applies in certain circumstances, which we'll go over later. We don't want to definitely overwhelm you, but there's different protocols and different places and environments where comprehensive assessment is required. If they seek care in an emergency room, that's one of the places it's required. Mobile crisis, residential treatment facilities, that gives us just a better idea of what's going on. So that's kind of an overview of all these lovely legal terms and what they all mean. They're different levels, but the ultimate goal is to get the child to the place that they need to be in order to get the assistance they need. And so these are kind of a little bit of the screening tools, some of the screening tools that I've utilized myself in my practice that I've seen utilized in different environments, primary care, pediatrics. One of the ones that is widely known is the PHQ-9. There's a shortened version of this, but again, I want you to get an idea of what we're talking about when we're talking about screening tools. It's questionnaires and rating. And the one on the left is the pediatric symptom checklist. There's 2 versions. There's a 17-question one that you see there on the screen, and then there's a 35-question one. And it gives us a lot of ideas as to which domains we're looking at. So for those of you that are therapists, are we looking at internalizing factors, externalizing factors? What are we looking at? And then this is a much larger one, a much longer one, obviously, but it's just, again, another example of potential tools that we can discuss based on your experience, based on your knowledge as to what would work best for the environment and what would work best for the population here in Nevada of children and adolescents. And then whatever tool we use, the ultimate goal is to make sure that we are assessing the behavioral health needs at that moment in time. And then again, that allows us to send them to whatever level of care they need at that point in time. So this particular tool gives us a lot more information as far as domains is concerned. And so if you want to read the settlement and you'll get a lot of verbiage constantly stating domains. So this is one of the tools that tells us a little bit more about what's going on as far as different areas, peer problems, pro-social issues. It gives us a lot more information. And then this is kind of what we see as an overview. And of course, this is kind of tentative. It's nothing set in stone, but this gives us an overview of what we envision this new system to be. And I'm going to give you an example. I've seen this example many, many times in my clinical experience. And of course, it's loosely related to a real life example, but a 10-year-old child, let's say it's a 10-year-old male, comes in to his pediatrician's office, with his parents. The parents are concerned. They're going over a normal well child visit, but said, this kid is suspended. He was suspended last week. He had kind of a meltdown. He turned over desks with computers, so the computers were ruined, kicked a teacher, was hitting peers. They had to evacuate the classroom just to make sure everyone was safe, and then he was suspended from school. So the pediatrician sees this concern, talks to the parents, uses a screening tool that they chose, sees with the screening tool, there's a risk. There's a risk that something else is going on that maybe preceded the kind of meltdown that occurred and resulted in the suspension. That kid is Medicaid eligible. Then a specialty managed care plan is offered to the child and to the family, saying, here's the plan. This is what it entails. It allows you to have more coordinated efforts, so wraparound coordination, so that we make sure you get to the place where you need to go. The vision for this is we're not just sending you out blindly and saying, here's a list of providers. You have a coordinator to coordinate that for you, not only to get your history, to learn about the family, to learn about the child, but to then say, I know the perfect provider for you. We're going to send you out to that provider. I'm going to help you make an appointment. I can attend the appointment if you want me to with you. I'll make sure that it gets done. I'll make sure that you're getting the care that you need to get. So in essence, someone in the middle to advocate for that child and for the family. If they are enrolled in that system, they get that coordinator. That coordinator schedules an intake with the family, learns all about their history, wants to become that advocate for the family and the child. That child and the family then are eligible to receive access to enhanced services. So some of these are new: youth and family peer support, some respite care, some supported employment. And again, that's up to the family, whatever fits their needs. That wraparound coordinator then determines, do they need a clinical assessment? Is this one of the examples where we skip to the comprehensive assessment? And in this particular example, that child was sent immediately to a comprehensive assessment just because of the level of acuity that he's gone through. In that comprehensive assessment, the parents report that the child has made self-deprecating comments, hates themselves, nobody loves them, they don't want to be alive, high acuity, right? So needs a comprehensive assessment. That child later treated, started on medication, completely different child. And again, this is things that I've seen many, many times. Completely different child, makes honor rolls, has new friends, functioning well at home, functioning well at school, but that child got to where they needed to go in a proper manner, and they got the care that they needed rapidly. And so we're trying to make sure that that is something that all children in the state of Nevada have, that they have the ability to get the care that they need at the time that they need it, but based on their goals. And so that wraparound care coordinator develops this specialized plan of care based on whatever the outcome of that comprehensive assessment is. And that person then follows that family to make sure they get the care that they need. So again, this is more of a tentative overview of what we envision the system to be. And of course, this is something we'll talk to you about and get your feedback on, because we want to make sure it fits everyone involved and not just what we think is the best idea, what everyone feels is the best idea and the best process for this child. So this is kind of what we oversee, or what we not oversee, but what we feel would be the overview of this particular system. And then here's a timeline, just to give you an idea of where we are versus where we would like to be. The tool selection is what we're discussing today, just as an overview again, right? And this is where the working group comes into play, and the settlement delineates that your feedback is vital. Your feedback is vital so that we can choose this particular tool or set of tools, and then we bring that selection of tools to the next level. So the state, the federal government, and then the independent reviewer that goes over and says, okay, here's what the working group has suggested. What do we do from this point forward? Once that tool or the set of tools is selected, then we go over that protocol. What are the timelines? How fast does this child need to have a comprehensive assessment, clinical assessment? How quickly should this wraparound coordinator contact the family? All those types of little intricate details, we'll go over that. And then working on compliance. How do we track and make sure that these things are actually done? And then we pilot the program. This is around September 2026, just to give you an idea of the timeline, so you don't feel this imminent pressure. We've got time. And then we launch it. And then again, we monitor it, making sure that it's being executed properly and the kids are getting quality care. So this is an overview again of our timeline and all the persons that we need to work with, including, of course, everyone here at this meeting. Really, really important. And then here's kind of the discussion that we wanted to have today. And again, it's open. This is just a loose kind of organization of the information we're trying to elicit. But of course, if you have any comments that you would like to make outside of these questions, feel free to do so. It's not stringent. The first question is for everyone. What is your experience with screening and assessment, and how can we improve it in this new model? And I'll just go over the other two, and then again, you can comment however you feel you would like to. The parents and team members, we have a different question for you. How do you see these tools being used? So this is something that we've discussed at length of, if you have a positive screening, what now? How can we best serve you and change the system from what it is today so it looks completely different? That positive screening tool, where do we go from this point? And then what kind of supports do you need to incorporate these tools? So again, I'm a practitioner, I work in different environments, right? And so the first thing that I discuss with the team is, this is great, but if my EHR doesn't have the screening and assessment tool in it, what does that mean for me? What cost does that mean? What time does that mean? How do I implement this? To the larger entities, the hospitals, the residential treatment facilities, how do you change protocol? What do you need so that we're aware of that and we keep that in mind when we create these protocols along with you? Is this something feasibly that you can implement? So these are our questions. We greatly value your input. So any comments that you have, we would love to hear.
Thank you, Dr. Pebbles. That was an excellent overview and truly walks through what I know is an incredibly complicated subject and really sets it up quite nicely. So excited for this discussion. And again, look forward to really focusing this conversation on the overall 10,000 foot, or I like to say balcony view of the world we're trying to build here, knowing we'll have a lot of time to get into those weeds and the real nitty gritty details that are crucial to the success of this. So Alana, I saw your hand up. I'm happy to start with you.
So we do a lot of screenings and assessments at CCBHCs, but we have a set protocol that we follow that the state has lined out for our assessments with children. So like age 11 to 17, we do the screenings of the Columbia, the Crosscutter. We do the DSM-5 for children and parents. We do a PHQ-9. We do the CRAFT to see if there's any AOD needs. And then we did just recently get rid of the ACEs, which I don't know why. I think that was a beneficial screening, but we also, as far as assessments, we do the Kumha and the CASI for kids. And so those ones, we don't really have a say in which ones we can use, which ones we can't use. We are told you use these ones. And so that's what we go with. Sometimes it is beneficial. Other times it seems a little bit repetitive, or that we're asking an age group questions that seem really irrelevant to them. So I really enjoy that you guys are going to be pushing to make it more streamlined for our age groups, because that has been a big issue that we fought for.
Absolutely. No, I appreciate you sharing that and recognize truly the alphabet soup of tools that exist in large part
Yes, sorry.
because of Medicaid regulation, right? And I know that
Yes.
a lot of it is on us to really determine what's the flexibility we have within federal regulation, knowing our CCBHCs, for example, and our FQHCs have very particular regulations guiding their
Yes.
work, but we do have some creativity and flexibility within that. And how can we move this model that we're building to be one that best serves our patients and is most streamlined across all our provider types and areas where kids are
I'm
receiving
excited
care.
to
yeah.
see what you guys come up with, so then we can argue that and say, look it, this is great.
Exactly. The good news is I work right down the hall from our folks that lead our CCBHC work. And so we will be working
Awesome.
with them very closely too. They are very much part of this process with our internal
Wonderful.
discussions because it's crucial, right? That we find a way to align what we're currently asking you all to do with what this new model can look like. So yeah, thank you for
Awesome.
that.
Thank you.
Yeah, of course. Thank you for the feedback. Ashley.
Hi, everybody. I'm so sorry. I'm on my cell phone. I'm picking up my kids. I just wanted to say I'm so grateful to be engaged in this conversation and really, really excited about the potential opportunity coming forward. I am the director of Nevada PBIS, Positive Behavior Interventions and Supports, and in my role, I oversee statewide implementation, evaluation of multi-tiered systems of support. And that is primarily conducted inside of the schools. And so one of the big core components of MTSS in the state is screening. And so I do think it would be really, really wonderful if we could start to consider aligning the work that the schools are doing from an MTSS perspective with the work that you all are creating to really get to a more comprehensive system of care with respect to the youth. And one of the things that I would just love to offer for consideration or discussion or future collaboration on is the universal screening that is happening inside of schools, which is a little bit different from the way that you're talking about screening. When we think from a school perspective, the screening level that you're talking about is more of what we would consider inside of a school system a targeted screener. So in the schools, we're actually going like one layer upstream from a prevention perspective and really focusing on universal screening. And that's that periodic screening of all students, so that the best practices in universal screening at a school level actually happens 3 times per year for every single student. And that's something that a lot of our districts and schools are starting to adopt. It is far from fully implemented, but it's really exciting and the screeners are valid. We're creating methodologies for collecting data and aligning those data for school teams to be able to use to then identify students who would potentially need targeted screeners. And then, like you said, you kind of go up from there. So I would just love to have a conversation or at least consideration of how we can maybe broaden exactly what you're talking about to potentially include universal screening that's happening at the school level. And the people who are engaging in that universal screening are school teachers. There's no special certifications that need to happen. And it's not very burdensome on the teachers from what we've heard thus far, because there are screeners that take 30 to 60 seconds per student. So it's very fast. It's, you could screen a whole class in an hour or 30 minutes to an hour, which is really wonderful. And there are many other states that have adopted legislation around universal school mental health screening. And I'm part of a multi-state collaborative on that. So I would be so pleased to engage in further discussion and communication about maybe how we can integrate some of that work into exactly what it is that you all are proposing. And I believe we might even have a meeting coming up together. So I will look forward to future collaboration, but I wanted to share my thoughts here as well. Thank you so much.
Absolutely. No, thank you for sharing, Ashley. I agree. I think our partners with you all and Nevada Department of Education are crucial to all of this. And I'm excited that, of course, this is not new. Nothing we're doing here is new under the sun. It's just trying to align the excellent work that's already happening and pull together all the resources we have to do it together. So I am looking forward to our conversation on Monday. I know Dr. Pebbles over the past 4 months, I believe even 5 months, has been working with Dana on a lot of this as well and gotten her feedback. So I'm excited for us to really think about ways we can align this. I agree. The more kids that we can screen in, the better we can equip our teachers with these supports. And then also a really clear handoff and direction once the youth does screen positively on these will be really crucial. So looking forward to that, and thank you for sharing. All right, Kim.
Wonderful. Thank you so much.
Of course, of course.
Hi, good afternoon. Kim Abbott with Legal Aid Center. I'm covering for Jonathan today. Just on when I saw sort of the flow chart of how you're going to kind of move and decide, and there's a section on input kind of from family, from provider. I just wanted to flag, because the target population is a lot of system involved youth, both the child welfare side and the delinquency side. Our kiddos in the systems have big teams, and some of the most knowledgeable people about them are the various people on their team, whether that's caseworker, probation officer, CAP attorney, CASA. And so I just wanted to sort of flag if we could make sure there's a way we're getting input, not just from a parent, not just from, one person who's made the referral, but that many of these kids have really big teams with lots of really, really valuable information about their functioning.
Yes. No, thank you, Kim, for that flag. I absolutely agree. I think the settlement does a good job of defining the child and family team in those appropriately broad terms, right? That's going to look very different for all of our youth, and particularly for our system involved youth. We need to be as broad and open in that definition as possible. So thank you for that flag. Agree, that's part of how we're thinking about it, and we can reflect that in that flow chart a little more clearly. So I appreciate that and look forward to working with you in the right ways. That's one thing to say we need the input, and the other thing to actually really get it and to figure out the right way to pull those folks together. So thank you for that. I appreciate it. All right. I believe Glenda, your hand's up next.
Hi, everyone. Well, I work primarily with Spanish-speaking families and that type of thing. So I also wanted to kind of ask if there's going to be consideration with that aspect of it, because I know we have a lot of families that are not fluent in the language, that some of the tools we're having to translate ourselves because they're not, offered. So I was just wondering if that was any consideration that's been taken also, because I used to be a CPS investigator as well. So I've worked both sides of it as now as a mental health therapist. So I was just wondering if that was a consideration that was being taken as well.
Mm-hmm. Absolutely. Thank you for flagging that. And yes, it is. That's going to be crucial. That language access is part of this tool, and it should not be on our providers to have to translate these tools themselves. So this is on our list. I know Dr. Pebble is a strong advocate for this work in the way that she provides care and the way she helps us inform our policy as well. So Dr. Pebble, if there's anything you want to add to that, or also Kim's previous comment, because I know you've worked with a number of these youth as well, would love to turn it over to you. But share your focus and concern, Glenda. That's going to be crucial for us to build a system that really works for all our kids.
Yes, absolutely. And so that's why I wanted to say thank you, Kim, for that comment. I just finished an assignment working with the foster youth in Vegas. And so I'm aware of those large teams, right? I've been in those meetings of a ton of people, the CASA workers and the, caseworkers and the legal experts, the CAP attorneys. And so that is extremely important to make sure that we involve all of them. And then Glenda, I could not agree more. Clearly, from looking at me, Pebbles is the name that I married into. So I am well aware that is important, extremely important. Today I'm in my scrubs. I just finished a rotation at urgent care, but I agree with you. When I walk into the room, in those rooms, I automatically get the person's shoulders relax. Like, you look like me, you understand me. It's very, very important, right? To be culturally aware, not only with the language, and make sure that these tools are translated in something that they can understand, right? Because mental health is complex. Even though I understand and speak Spanish, I don't know all the mental health terms. So even for me, I had to be like, well, I don't know how to say that. And I don't know how to say that. So I had to look it up to make sure that they had a fair turn to tell me what they're feeling and to tell me their experiences. And then I would be able to communicate back to make sure that care was proper, right? So I could not agree more. That's one of my priorities, to make sure that this is translated into languages that are comfortable for our patients and their families. So absolutely, thank you for your comment.
Thank you.
Well, thanks, Glenda. Leah.
Hi, everyone. So my name is Leah, and I'm a parent that has gone through a lot of mental health with my daughter, and I absolutely love being a part of this group. I love the feedback that you guys are providing today, just because, the screening and assessment is really important. And I think as a parent standpoint too, I love that they're going to implement this in schools as that first plan of action. And I agree with Kim too. I mean, I've been very fortunate of having a great support group throughout the community. But I also, with Glenda too, it's not just Spanish speaking. I mean, as a parent and going through this, mental health is complex, like Dr. Pebble said. And so understanding it as a parent, but then also with these assessments, if we can somehow streamline it to where a parent isn't going through an assessment all the time, because we have other things to focus on too. And our child is a priority, right? And it kind of gets blurred when you're having to take care of so many different things at one time. So I think it's really important to be able to streamline those assessments and really communicate with all of the different entities where you're not doing the same assessment over and over again. And that's just my input as a parent. So I hope that that's also taken into consideration of how we're going to share this with other providers to make sure that everything is communicated.
Mm-hmm. Absolutely. Well, first and foremost, Leah, thank you for being here. We love to have you on these meetings every month, and I appreciate you taking the time to share your experience. I absolutely agree. It's the focus on one youth, one assessment, and ensuring that travels with them in every place they go. So we're not re-traumatizing our youth and our families as we're having to re-ask questions over and over is absolutely crucial. And I know Dr. Pebbles, that's a key part of your experience as well. I'd love to, if you wouldn't mind, Leah, if I could ask you a question back, and then Dr. Pebbles would love to open up to you as well. I'm curious, in your experience so far working in support of your daughter throughout Nevada, how often would you say you've had to go through some of those re-screenings, reassessments? Could you give us a ballpark of what that's looked or felt like? And what would you want that kind of cadence to feel like in order to keep that up to date, but also to not have to be re-asking these questions over and over?
Right. It depends on the scenario and then how many people we get on board. Unfortunately, a lot of help that we were provided didn't come to us until after she became part of the judicial system. So that's always been difficult for us. And then it just seems like every new entity we're having to do the same assessments again. And there were times where you were doing them twice a week or once a month, or I mean, we've been going through this for multiple years. So it's, I would say at least one a quarter for the
Yeah.
So I mean, it does get really involved, but also I understand that going through those ages, her behavior changes, right?
Mhm.
So those assessments also change, but you know, if we could streamline it to be once every 6 months, you know, or once a year, that would really be beneficial so that I can focus more on her team, what she needs, scheduling those appointments. Because as a working single mom, you know, that's a whole nother job that you're adding, right? Is taking on those phone calls. And a lot of those phone calls, you respect everybody's time and their work schedule as well, but they don't correlate always. So if you're working at 8 to 5 and the people that are doing the assessments are also 8 to 5, you're having to take a lot of time out of work. And if you're not in a place where you have a work that is supportive of that, or FMLA, or, you know, paid time off, that also becomes a big struggle and a big stressor as well.
Mhm.
Mhm.
I could not
Absolutely.
agree more. Yeah. So I will say, one of the reasons why I ended up pursuing this line of work, I intended to work with the veterans. My father's a disabled vet and with some pretty severe PTSD. And it was a psych nurse practitioner that changed his life and then changed our lives, obviously, right? But I have 4 kids, and one of them was diagnosed with bipolar disorder when she was 14. And so I understand what you're saying, not only having to go get an assessment, right? And figure out, I now have to choose between going to work and providing for my family and going to get this care for my child, which I know is important. And that's something that is at the top of my priorities. And so that's why we're trying to work with the school district to get them care where they are and find providers that are willing to do things like work on Saturdays. Like I myself work on Saturdays to accommodate families and accommodate parents that don't have typical schedules and can't really take off from work. And I agree, not having to re-traumatize the kids by asking them the same things over and over and over is a priority as well. You know, as a provider, I've heard some really horrendous stories, and I would hate to have them repeat that over and over. And so that's a priority, is one child, one assessment, making sure that we're not just re-injuring them constantly, and having some type of database that everyone could access. So what I collected as a practitioner, someone else down the line can see everything that I've done, including the schools. So we're all on the same page as a team for the child and not just these siloed different entities. So that's definitely a priority.
Absolutely. Yeah.
I
Thank you,
love
Dr.
that.
Pebble. Or yeah, go ahead, Leah. Go ahead.
Oh, I was just going to say thank you so much. I love that, and I really, really appreciate that.
Absolutely. Thank you, Leah, for sharing more of your experience. And I agree, Dr. Pebbles, thank you for sharing that as well. Glenda, I know your hand's been up for a bit. Do you have something that you wanted to add here as well?
No, I think that I forgot to take it off. Sorry.
Oh, no worries. You're always welcome to share more. So anytime.
Thank you.
I saw Karen's question come through in the chat next, and then Brandon will move to you. Karen's asking, have you decided at what point SED or serious emotional disturbance determination will be done? Dr. Pebbles, do you want to take that one, or do you want me to? Happy either way.
Yeah, so the key is with that screening tool to give us kind of a heads up, and then with that clinical assessment, comprehensive assessment, to then go that one step further and say there's something here that's underlying a little more serious, which I've seen multiple times where we think it's depression, we think it's anxiety, and it's something a little bit more serious. Hopefully we'll be able to do that. That should kind of overarch things like FAS or fetal alcohol syndrome, things like autism, spectrum disorder that I see often. I used to work in juvenile detention, and at that point, 16, 17 years old, if we have a determination of the FAS or ASD or anything like that, at that point, we're kind of backtracking. We're walking up and down escalator, right? So it's hard. So the point of all these assessments is to try to get ahead of that. So we're aware we can get them the help that they need and not wait till they're 16, 17, 18 and they're in juvenile detention center and they can't be placed at a group home because they're violent or whatever the case may be. But that serious emotional disturbance is key. I've had a lot of kids that presented with depression and ended up to have some pretty serious psychosis that we didn't catch till later down the line. And so whatever assessments, whatever tools we end up choosing will be key to get that information as fast as possible. So again, we can get them the care that they need, right? And this is something that I tell my patients all the time. I need you to be truthful with me, because if you are dealing with psychosis and that's something you're struggling with, I need to know immediately because it only gets worse. And at some point I won't be able to reverse it. So I want to help you, right, to live the best life that you can. And that serious emotional disturbance is definitely one of them. I hope that answered it. If not, feel free to ask me more questions. Sorry.
Oh, thank you, Dr. Pebbles. Yeah, so in that kind of tentative process map, that blue and green slide, it would be what I'm hearing from you, Dr. Pebbles, is really more in that comprehensive assessment box is the phase where that determination would be done. Yeah, thank you. All right, I see Dina's hand up next. Good to see you. I referenced your name and you appeared.
I'm glad to be here. I'm so excited about all this work. It's just dreamy. I would like to propose that we really consider social determinants of health rather than SED. I mean, we are one of the only states that are really sticking with this language around severely emotionally disturbed, which sort of makes me cringe. Why would you be called that if you have depression? Or we do it with adults too, SMI. And so I would, if we have an opportunity to consider social determinants of health and lean more heavily onto Z codes rather than F codes, especially in youth, I would love that. I mean, I know exactly what Dr. Pebbles is talking about, and I do agree with that, and that there are some youth that would require a diagnosis and that would help them get access to the most appropriate level of care. However, it is not every single youth who scores a 3 on a CASI. I mean, and right now that's our determination in Nevada. If you score a 3 on a CASI, you're SED, which I don't like. So if we have any opportunity to reword it and to get away from labeling and more into whole child perspective, social determinants of health, I would love that. I really want to do that in schools where we can screen and scoop them up quickly and not have to like give them this label.
Absolutely. I appreciate you sharing that. And I know our team shares that sentiment as well. We are actually exploring Z codes right now as an opportunity to increase access to some of these services earlier. And I also will say our settlement, while it includes the SED term, also includes a behavioral health disability as the overarching term. So we're trying to use that as the broader term, knowing that none of this language feels 100% right often to anyone's experience as they're going through this. So I appreciate that. But agree in terms of care and thinking about what mechanisms are we putting in place to access services. I definitely appreciate the question behind the question there. And I know that our conversations on the peer support side really touched the ways that we're trying to figure out how can we decrease those barriers, get folks access to these services as early as possible and not wait till farther down that spectrum. So thank you for sharing. Dr. Pebbles, anything you want to add there before we go to Brandon?
Yes, thank you, Dana, for your comment. I agree wholeheartedly that we have to keep in mind the social determinants of health definitely have a major impact on mental health and the diagnosis, right? And the trajectory of that person is key based on what they have dealt with in life. And I had someone, when I started out as a psych nurse practitioner, correct me one time when I was in Mallory Crisis Center. And I said, the person is schizophrenic. And she said, no, he's not schizophrenic. He has schizophrenia. And I was like, oh, corrected. You are correct, madam. He is not his diagnosis. He has the illness. So thank you, Dana.
And Brandon, I know you had your hand up earlier. I'm sorry I missed that. Looking forward to your feedback.
No worries. I was just, making some comments as far as what I'm hearing, when we're talking about some of this stuff. It made me wonder, like, what are the differences that we see sometimes as professionals between the different assessments? Like if you ever received a records, from somewhere, and then you get a client and you're like, I'm not seeing any of this. but now it's my job to treat this person, but this is the evaluation that I'm getting, and I'm not seeing that. So I wonder how many times that comes into play. I don't know that this one doesn't have a solution following behind it or anything, just something to think about. Same for parents. You know, I heard the parent talking. I wonder how many times that she goes somewhere and they're like, oh, your child is diagnosed with this. And then she goes somewhere else. No, your child is diagnosed with this. And now all of a sudden, you know, you're you know, as a parent or as the child, you're probably confused about some of the way things are going and where your treatment's going and what's really going on. But I also know as a professional, they can present differently at different times, right? So I don't, again, no solution here, just things to think about. And then it also takes me back, I think Dana had said something too about using Z codes and the CASI level of 3 and stuff like that. Well, that also ties into insurance. And then when you get into the insurance world, they don't want to cover it if it's a Z code. They don't want to cover it unless the CASI score is this high. And they don't want to cover these additional screenings as well. So that was another thing. It's like we need more screenings for some of these children based on what they're presenting to even find out, you know, which path we should go down. But I hear at the state level, I think that, you know, the firemen, the policemen, you know, their unions, they didn't want to pay the extra money that it might cost to have somebody always screen for autism and ADHD and depression and substance use. Like they don't want to add those costs. So the insurance providers are lobbying against us to even get those things covered. And that's like the basic window, right, into treatment is these screenings. And you know, so again, we're kind of at this impasse where we're telling people what we need, but we're getting that pushback because of what the implications could be on a financial level, right? And lastly, I know even prior authorization, like I talked to, you know, Stacy once at trying to get, you know, a push for us to get more screenings without prior authorization. And then, you know, their immediate response is, well, what about fraud, waste, and abuse? You know, if we allow providers to bill for all these screenings, next thing you know, they think they're going to get a kid that's being billed for 12 screenings in, you know, in a couple weeks or something. And you know, I'm sure there's bad apples out there. Of course, that's not the intention or the idea behind it originally. But when she said that, I was like, man, like, what do we do here? You know? So it was just a few things to like really consider and the impact and then how it ties into the insurance world, which is how we get these things provided. So like, sorry, no solutions right now. Just something, this is a work group. I hope we're all thinking about it, right?
Yeah, no, thank you for your comment, Brandon. That was perfect. But that's why one of the key points of all this transformation is one database, or having access to this database where all of those assessments could be uploaded, right? We're all on the same page. We all see the same things, but I could not agree more. A lot of treatment and a lot of diagnoses is more dictated to by insurance and those kind of measures, right? Like we need this code in order to do this, and we need this assessment in order to do this. And so that definitely is something that we're keeping in mind, right? Because I deal with that every single day.
And I think like what you said, that might be some of the solution. If a database had the assessment, and not only am I looking at someone's brief form of this assessment and then they gave a diagnosis, but I didn't see why they gave that diagnosis. Maybe in this database, I can say, oh, the child presented this, which led to this diagnosis, and that helps me understand it a little bit more. So that could be helpful.
Mm-hmm. I agree. I agree with you completely. I used to see kids all the time and they came out of the hospital and I'd be like, well, what did they diagnose you with? Or why'd you take this med? They're like, huh? And so it's like, it'd be really helpful to be like, what is your rationale? Why did we start this med? Why are we diagnosing them with this particular illness? What did you see that I didn't see? Because kids are kids, right? They'll mention one thing to one person, another thing to another person. And we're like, well, we need to all be on the same page and have the same picture, because it definitely affects their care. So I could not agree more. And that's the goal, is to have everything in one place so we're all on the same page. Even the schools, you know, what I heard is kids get discharged and the schools don't know what's going on. So they can't help either because they don't understand. So I agree. Thank you again, Brandon. I agree.
Thanks.
Yeah, thanks, Brandon. Alana.
So I was just going to say, I couldn't agree more with what everyone is saying right now, because even where I'm at, I'm the psychiatric medication provider, but everybody sees therapy. We have golden thread rules set up in our new EHR so that everything is tied in together. But I feel like sometimes they forget about medical. So I have to put codes in order to get medications approved. And so a lot of times it's a fight back and forth of, well, that's not what I saw. Well, this is the code I have to put in for a medication. It can't get approved without, with a different code. And so then we're in a bind because, trying to do that golden thread, how's everything tied together? Where did it come from? Well, the only way I can get a medication is if I put this one in, and it doesn't always fit, and it's horrible. And I hate putting any sort of diagnosis, especially on a child, just so that I can get them a medication that is going to be beneficial for them, because it can sit with them for life and it could alter their path in life having the wrong diagnosis. And so I definitely agree with everybody that there's got to be something that we can do better that's not going to be that diagnosis that can change the course of their life. It's already bad enough. They have all these roadblocks. The last thing I want to do is try and help them and set them up for failure.
Absolutely. I appreciate that, Alana, and I'm grateful that the settlement agreement also really sets that tone as well. It's really focused on how can we go upstream, get folks access to services even prior to diagnosis, which is partially why we're looking to expand the population for our specialty plan beyond just that focus population, which is really tied to the determination or diagnosis, to kids that are at risk prior to any sort of formal diagnosis, and really get them in to the services that they need as early as we possibly can. So I appreciate that. I know always easier said than done. And there's a lot of nuance to striking the right balance.
It has to start somewhere.
Exactly. So thank you. Fully appreciate that, and know that that's a big area of our focus as well. We are getting close on time. So Jessica, I think you may be our last comment for this section today, but I'm really looking forward to hearing what you have to say.
Can you hear me?
Yes, we can.
Okay. I think that just to keep in mind, when families don't want all of their kids' clinical information from a CUMHA or from an assessment shared with everybody in the world, how that's going to be navigated, because family voice and choice on whether or not, while we all as the professionals really do want that information and we see the value in it, if a family says, no, I don't want this entity to have this unless I have to, or they, I don't think just because they are involved in this, they get an assessment or they get screened, that we have this, this system that everyone has access to. I think that is a very slippery slope that sets up families for not seeking services or seeking help once they recognize, oh, shoot, okay, so I gave you this information and now my kid's school and pediatrician and all these people know about their sexual abuse history or know about my substance history that I put in, that I gave you as part of a CUMHA, so that you could treat them correctly. And I do think that is something, in regard to, already I have seen it with mobile crisis, where when we have to talk about what we're reporting out on, some families they don't want that service. If it means that they have to do it in this certain way with all these people knowing their information. And I think keeping in mind immigration status and things like that at this point also really puts people on a slippery slope as well, if they are like, oh gosh, who all is going to know my information? So just something I think is really important. How do families have voice and choice in where their information goes as we're navigating this system?
Absolutely. That's an excellent point, Jessica. Thank you for sharing that. I couldn't agree more. The family voice and choice is fundamental. It's a fundamental principle of this entire transformation, and is really supported by that settlement again. So I really appreciate your kind of constant refocusing or reminders there, because it's crucial. And to Dr. Peppel's earlier point, the data sharing component is incredibly complex and is not a part of it that's coming soon. So we really do have some time to have these really thoughtful design conversations about the right level of access and consent that's going to be involved in that. So really looking forward to your contribution and leadership in those conversations as well. And I appreciate you raising that here. So with that, we will move to our wrap up here. As always, want to thank you for taking time out of your busy, especially summer schedules, to be here today. We look forward to seeing you at our next meeting. We'll be back on our second Thursday of the month routine in July, on July 10th. And as we mentioned, this is the first of many conversations to come, and we'll have some more targeted conversations with providers and with youth and families. So stay tuned for a lot more opportunities there. But really want to thank you again for an excellent kickoff discussion today. So with that, we will move to our public comment period. As a reminder, no action may be taken upon a matter raised in public comment period unless it's already been included as an agenda item. Comments will be limited to 3 minutes per person, and please remember to state your names. That way we can have that for the record. And any working group representative that joined by phone and didn't get a chance to introduce yourself, feel free to come off mute now, or raise your hand and we can manually unmute you if that would be helpful. Thank you, Shayla. It's great to have you here, and we will mark you down. Wonderful. Yes, James.
Yes, the sexually managed care plan will cover the foster care population. Will it also cover former foster care members and adoption assistance populations?
Yeah, great question. So as part of the settlement, former foster youth up to age 26 are included within the focus population, so would be part of it. Adoption assistance will likely be included there, but we're still working out some of those nuances. So if you have particular input or recommendations there on how we approach that, that's something we'll be discussing at those eligibility groups in future meetings. But if you want to shoot that to us over email, we'd love to see that now as well. So thank you.
Thank you.
Cool. I see one more hand up, John.
Hey, Jonathan Norman. I joined late, so just getting my name out there, and good discussion. Thank you.
Wonderful. We're glad to have you, Jonathan. Thanks again for logging on, and I appreciate it. All right. With that, we will close. Thank you again for your time and for the discussion. Thank you, Dr. Pebbles, for walking us through what's an incredibly complicated thing very clearly, and I'm looking forward to many conversations with this group to come. So take care and have a lovely evening.